This is the second part of the introductory lecture, and I'm going to be doing meninges and cerebrospinal fluid. Now let's look at the layers which surround the brain and the spinal cord, and these protective layers are known as meninges. There are three of them: the dura mater, which is known as the pachymeninges, and the arachnoid and pia mater, which are together known as leptomeninges. Pachy means thick and lepto means thin, and you will see how the arachnoid and the pia mater are very thin. That's why they're known as pachymeninges. Let's first look at the dura mater, which is the outermost layer, and you can see the dura mater up here, and this is a very thick layer. Most people describe it as being composed of two fused layers. One layer is fused with the inner aspect of the skull. As you see here, it's fused with the inner aspect of the skull, and they describe it as the periosteal layer. And the second is the true meningeal layer. Now others say it's really not made up of two layers. It doesn't matter how you look at it. The point is that you can't define these two layers, but the dura mater is fused to the inner aspect of the skull, and in certain areas it kind of separates into two parts, and you can see that separation up here, where it is one part is fused to the inner aspect of the skull, and then the second layer kind of moves away from it, and in between these two parts you have a venous sinus present, and this here, what you're seeing, is known as the superior sagittal sinus. So in certain areas of the brain you'll find that this dura mater kind of separates into two layers, and in between the two layers you have venous sinuses present, and these venous sinuses are important because the absorption of cerebrospinal fluid takes place in these venous sinuses. The most important venous sinus is the superior sagittal sinus. You have other venous sinuses present, and when we do the blood supply of the brain we'll be looking at that. So that is the dura mater, and outside the dura mater, that means between the dura mater and the skull, the space outside the dura mater is known as the extradural space. And right here I would like you to concentrate on what you see in this extradural space. It's a very, very narrow space, and in that space you see meningeal blood vessels. So here, right here, you can see these meningeal blood vessels, and you can see that up here too in a more magnified image. So you can see this is the dura mater, which is fused to the periosteum of the skull, and in this case it's really called endosteum of the skull because this is the inner aspect of the skull. So this is the endosteal layer of the skull, and it just separates a little bit from the endosteal layer where it has to accommodate these meningeal blood vessels. Quite naturally, the function of these meningeal blood vessels would be to supply the meninges. So you can see how it can supply the dura and the arachnoid mater. And the vein, the meningeal vein, will drain the blood from the arachnoid and the dura mater. So the meningeal blood vessels lie in the extradural space. Now, also seen up here, you will find that you have a vein which I have labeled, which is called an emissary vein. This emissary vein is really a connection between the blood vessels of the scalp with the bone marrow present inside the skull, and the bone marrow present inside the skull is known as diploid. So you can see that connection up here. Now this connection is important because if there's any infection in the scalp, that can spread to the bone marrow or the diploid. Now these meningeal blood vessels also have connections with the diploid, the vein. So you can see that from the scalp the infection could spread into the diploid. From there it could spread into the meningeal veins, and from there it could spread into the meninges. So that's why the emissary veins are important, and scalp infections can prove to be extremely dangerous. The second layer is the arachnoid mater, and if you look here, this is the arachnoid mater up here, and again if you look at a magnified picture, you can see here this is the arachnoid mater, and the space between the dura mater and the arachnoid mater is known as the subdural space. And then in a little while we'll see what traverses the subdural space. Now this arachnoid mater is a very thin cobwebby layer, and you can see it up here. You can see that it's a very cobwebby thin layer, whereas the dura, if you look here, you can see how the dura is so thick and it's almost grayish white in appearance. Now below the arachnoid mater is a space present which is known as the subarachnoid space, and this subarachnoid space contains cerebrospinal fluid. The innermost layer is known as the pia mater, and so this is the innermost layer, which is the pia mater, and here is the pia mater. This pia mater closely encloses the brain, so you can see it kind of follows the grooves or what are known as the sulci of the brain, and you cannot separate it from the gray matter. So if you look here too, you can see it's going in and comes out this way, so you cannot separate it from the surface of the brain. So hence there is no space between the pia mater and the brain itself. So these are the three layers that you see: the dura mater, the arachnoid mater, and the pia mater. The space above the dura, that means which is between the dura and the skull, very, very small potential space in which you find the blood vessels, the meningeal blood vessels, that space is known as the extradural space. Then between the dura mater and the arachnoid mater, you have a space which is called the subdural space, and I'll tell you what passes through the subdural space in just a bit. And then between the arachnoid mater and the pia mater, you have the subarachnoid space where you have CSF. You have cerebrospinal fluid, and in the extradural space I told you had the meningeal blood vessels. Now if you look at this image up here, you will notice that there is this vein which is actually a blood vessel present in the subarachnoid space. So in the subarachnoid space, apart from CSF, you also have major blood vessels which supply the brain. And these major blood vessels are known as cerebral blood vessels because they are going to supply the brain, cerebral blood vessels. So they are both arteries and veins. Here you can see an artery, and here you can see the same artery, and you also see a vein up here. So that's why you have both arteries and veins in the subarachnoid space, and they are bathed in the CSF. So in the subarachnoid space we have CSF which bathes the cerebral blood vessels. Now the veins which are present over here, the arteries obviously grow to supply the brain tissue. The veins which are present over here, these veins drain into those venous sinuses which are present in the dura mater. But in order to go to the venous sinus, as you can see from this image, they are lying in the subarachnoid space, they pierce the arachnoid mater, they pass through the subdural space. So you can see in this narrow part here, they are passing through the subdural space, and then they go and drain into the venous sinus. So the subdural space has veins, and these are your cerebral veins. So these are the cerebral veins which are going to drain into the venous sinuses. And it is important to remember these because when I do the clinical applications, you'll see how these veins, which are very, very thin, they can collapse or they can be torn if there is any problem. If there is, for example, in shaken baby syndrome, when your baby is shaken violently, then the brain kind of moves about, and then these veins will move about this way and they can be easily torn. Now let's examine the dura mater in a little more detail. And here we are looking at the dura mater, and here you can kind of see the two layers up here. Now these two layers are not easily separated, or rather you can't separate them in most parts of the brain and the only place you can separate them is where those venous sinuses are present. And here you can see this is the outer layer, and then this one here is the inner layer, and in between them is this venous sinus. Now on the outside of the dura mater you will see these blood vessels, and these are those meningeal vessels which you saw, and these naturally, as you can see, will supply the dura mater. So you can see here again meningeal blood vessels on the outside or lying in the extradural space. Now within this venous sinus you will find large tufts of or structures which are known as arachnoid granulations. They are really called arachnoid villi, and they are given the name of granulations when they become extremely large. And these are nothing else but these are really arachnoid tissue. So arachnoid villi are really parts of the arachnoid mater which have gone through the dura mater and opened into the venous sinuses. And again we'll see them in relation to the cerebrospinal fluid. So for now, just look at them and see that these are present in the venous sinuses. These are portions of the arachnoid mater, and they make their way through the dura mater to open into the venous sinuses. Now the dura mater, where it separates and forms, you can see you can see the two layers, and where it encloses the venous sinuses, in those areas the dura mater forms partitions between the brain tissue, and these partitions, you have three of them. You have one which is known as falx cerebri. The second one is called tentorium cerebelli, and there's a third insignificant one which is known as falx cerebelli. Falx means sickle shaped, and here if you look you can see the first one, which is this one, which is falx cerebri. So here the dura mater has gone in to form a fold, a sickle shaped fold, and this falx cerebri is present between the two cerebral hemispheres. So that's why it's called falx cerebri. So it's between the two cerebral hemispheres. This falx cerebri then comes and meets a tent-shaped fold which is known as tentorium cerebelli. So the tentorium cerebelli meets, as you can see, the falx cerebri. This tentorium separates the cerebral hemisphere. So you have one cerebral hemisphere which is present here, and under the tentorium is the cerebellum this way. So just to show it to you, so if I was to draw, so this is the cerebral hemisphere this way, and then you have the cerebellum underneath. So this tentorium lies in this portion up here. So it separates the cerebral hemisphere from the cerebellum, and in particular it separates the portion of the cerebral hemisphere which lies here is the occipital lobe of the cerebral hemisphere. So here this is the occipital lobe. So it separates the occipital lobe from the cerebellum. So the tentorium has the occipital lobe lying on top and the cerebellum lying below. And the cerebellum lies here in a region which is known as the posterior cranial fossa. So this region is known as the posterior cranial fossa. So the occipital lobe lies on top of the tentorium and the cerebellum lies below the tentorium. The third part or third partition which is formed by the dura is a very small, insignificant partition. You may not even see it sometimes, and this is known as the falx cerebelli, and this lies between the two cerebellar hemispheres. And again, like I said, it's not very important, and this is seen in the posterior cranial fossa. Now the function of these partitions is to provide protection to the brain, and they prevent parts of the brain from hitting each other, and so hence they are very, very useful. Now another thing to notice in this image is that the tentorium, if you look, has a free border. It's a U-shaped border, and this border is present because it allows the brain stem to pass through this region, and then that a part of the brainstem becomes continuous with the spinal cord below. So it allows the brainstem to pass through. Now let's look at the next image, where we are looking at the blood supply and innervation of the meninges, and especially the dura and part of the arachnoid. Now the blood supply, as I said, is by the meningeal blood vessels. So you can see the middle meningeal artery is a very important blood vessel supplying the meninges, and this middle meningeal artery enters the skull through a foramen inside, and then you can see how it's passing through, and this is where it actually forms grooves on the inside of the skull, and you saw some of these. So let's go back to the previous slide, and here you can see these meningeal, this is again part of the middle meningeal artery, or it could be the vein, you can't really tell from this image. So this middle meningeal artery, and it's accompanied by the middle meningeal vein, so they form these grooves inside, and they supply most of the dura. The lower aspect of the dura on this aspect in the posterior cranial fossa has some other arteries, for example the occipital artery and the ascending pharyngeal, so they also kind of help to supply this region of the dura mater. The veins, the middle meningeal veins and the veins which accompany these arteries, they drain and they pass out and finally get out of the skull. The nerve supply is important. The supratentorial part, that means the part above the tentorium cerebelli, is supplied by the fifth or the trigeminal nerve, the fifth cranial nerve, and this nerve is also called the trigeminal nerve. And you will do it in head and neck. The trigeminal has various parts: the ophthalmic division, the maxillary division and the mandibular division. Most of the supply is by the ophthalmic division of the trigeminal nerve. So if there is any problem in the supratentorial part, for example if there's a stretching of the supratentorial part because of meningitis or intracranial injury, or there's a rise in intracranial pressure, the patient feels violent headaches, and usually this is seen in the frontal and the parietal regions of the head. So you'll get frontal headaches or parietal headaches, and that's because of the nerve supply. The infratentorial part of the dura mater is supplied mainly by cervical nerves. So the infratentorial part, which is underneath here, is supplied by the cervical nerves. Now, as I said earlier, the supratentorial part, the main supply is by the ophthalmic division of the fifth cranial nerve. Parts of it in the middle cranial fossa in the supratentorial region are supplied by a branch of the mandibular division and by maxillary. But most of it, as you can see, is supplied by the ophthalmic division of the trigeminal. In any case, all of it above the tentorium is supplied by the trigeminal. Below the tentorium, it's supplied by the cervical nerves. And this is the reason when there is acute meningitis, which involves the posterior cranial fossa, which lies below this tentorium, the person has neck rigidity. So acute meningitis involving the infratentorial part, you will often see neck rigidity in these people. There is retraction of the head. So let me write that again. So you have neck rigidity, you have head retraction, and the person has violent occipital headache. And this is because the neck rigidity and head retraction and this occipital headache is all because these cervical nerves, which supply the infratentorial part, also supply the muscles of the neck in that region and the skin in that area. So that's why because the muscles also get affected, so you have neck rigidity and head retraction. And of course the headache, occipital headache, is because this region here is supplied by the cervical nerve. Now sometimes when people have subarachnoid hemorrhage, again in the in the posterior cranial fossa, again these people have violent occipital headaches because the blood swirls in that posterior cranial fossa and it irritates the meninges there, and those meninges are supplied by the cervical cranial nerves, that infratentorial part, leading to violent occipital headaches. So it's very important for you to be able to correlate clinically, if somebody has any problem in the supratentorial part, why they have symptoms which are seen in the frontal and the parietal region, whereas if there's anything happening in the infratentorial part, why the occipital region or the neck region is affected, and that is because of the common nerve supply. The dura mater is fused to the sclera of the eyeball, and just to show you the clinical significance of this, so if you look here at the eyeball, so let's just use this color to draw the eyeball. So this is the eyeball and this is the optic nerve. We have the dura mater, which is fused to the sclera of the eyeball. So that's the scleral layer that it's fused to. Below it is the arachnoid mater. So here's the arachnoid mater, and that follows the optic nerve, and then that also gets fused higher up. So this space that you're looking at, this is the subarachnoid space. So you can see how the subarachnoid space is surrounding the optic nerve. This is the optic nerve. Now the blood vessels, the retinal blood vessels, the retinal artery and vein, which are present outside, you can see they have to pierce the dura mater and the arachnoid mater in order to get in, and then they get into the optic nerve, and then they go to supply the retina. And same goes for the vein. So this is how they go in. Now you can see that if there is a rise in intracranial pressure, that will affect these retinal blood vessels as they are crossing this and piercing through. So they get affected and they can collapse. And so sometimes if there is raised intracranial pressure, the best way to look at it is to examine the interior of the eye, where you will see whether these blood vessels have been affected or not. So that's one area where this subarachnoid space is clinically significant. Now let's move on and look at the spinal meninges. Now the spinal dura mater, unlike the cranial dura mater, is not present in two layers. It's like a test tube, and it is attached to the rim of the foramen magnum. So it comes all the way down, it's attached like this, like a test tube, and it travels till the level of the sacral 2 vertebra, where it stops short, and then after that there is no dura mater present. And this is surrounded on the outside by a fat and by a venous plexus, which is known as the vertebral venous plexus. So in a cross section which you're looking at over here, you can see that this is the dura mater here, and outside of the dura mater, which is this area here, you have fat present, and you have this venous plexus which is present here, which is called the internal vertebral venous plexus, because it's present inside the vertebral canal. The arachnoid mater, which is the second layer, here it's very close to the dura, so it looks like the dura and the arachnoid are the same, but it's not. This, if you look carefully, the arachnoid is the inner layer and then the dura is the outer layer. And you can see here, this is the arachnoid mater, this is the outermost dura, this is the arachnoid mater, and this lies on the inside, and the subarachnoid space which is present here, which is this area here, this area, the subarachnoid space, which is this one here, that is continuous with the subarachnoid space inside the cranial cavity. So it's continuous, and this continuity is very, very important. The pia mater, which is the innermost layer, lies inner to the arachnoid mater. It follows the fissures of the spinal cord very closely. You cannot separate it, just like in the brain. But the difference is that this pia mater actually has several tooth-like projections. So you can see these tooth-like projections. These are known as denticulate ligaments. and you can also see the tooth-like projection up here. And this pierces the arachnoid and goes and attaches to the dura mater, and it helps to anchor the spinal cord. So these denticulate ligaments are seen at different intervals, and they are rather important. Now, one thing I want you to notice in this image here is this vein that I have labeled. This is called the basivertebral vein. This is a vein which is present within the body of the vertebra, and it passes out through the body of the vertebra on the posterior aspect. And what it really is present there is all the bone marrow cells pass out through these veins. They enter the basivertebral vein, and then they pass out and join this vertebral venous plexus. So that's its normal function, to connect the bone marrow inside the body of the vertebra to the internal vertebral venous plexus. But this internal vertebral venous plexus is valveless. There are no valves, so blood can flow in either direction. And this internal vertebral venous plexus has connections with many organs. For example, the lungs. It has connections with a lot of the pelvic and abdominal organs. So if there is a cancer of any one of these organs, so imagine the cancer cells from any one of these organs can travel, because this is valveless and blood can flow in either direction. It can travel into the internal vertebral venous plexus. From this internal vertebral venous plexus, it can go into the vertebral bodies, and secondaries or metastases can be seen in the vertebral bodies. The second disadvantage is that this internal vertebral venous plexus also has connections with the spinal blood vessels. So cancers from here can travel here and get into the spinal cord, and then travel all the way up and go into the brain. So you can have metastasis in the brain too. So that is the importance of this basivertebral and the internal vertebral venous plexus. Now let's look at lumbar puncture, which may be done for diagnostic purposes, or where you remove cerebrospinal fluid and you want to study that in case there's an infection or something. Or you can also administer anesthesia, and you inject the anesthetic agent into the subarachnoid space. Now, in order to do that, you first have to do it below the level of where the spinal cord ends. Now, in adults, the spinal cord ends at the lower border of the lumbar 1 vertebra or the upper border of lumbar 2. So anywhere between L1 and L2. And in children, it ends lower down at the level of L3. And this is the point where the spinal cord ends. And after that, the nerves are all present as a sheath. And that sheath of nerves is known as cauda equina. Cauda meaning tail, equina is for horse. So because this sheath of nerves looks like a horse's tail, so that's why it's called cauda equina. Now, below this level, that means below L2 in adults and below L3 in children, you just have this sheath of nerves, and these are present in the subarachnoid space, which travels all the way up to S2. If you remember that the dura mater ended at S2, and so did the arachnoid mater. So this is the subarachnoid space present here, and this subarachnoid space is rather dilated, and it's known as the lumbar cistern. It's called the lumbar cistern. So when you do a lumbar puncture, in adults you'll do it below the level of L2, and in children you will do it below the level of L3 because you don't want to hit the spinal cord. So in adults, usually it is done between L3 and L4, and in children it's done between L4 and L5. So the patient, as you can see, is put in a lateral position, and they are asked to flex, their spine is flexed, so they bend over, getting their arms and their knees close together so that the vertebral column is you can delineate it easily. And then you look for the highest point of the iliac crest, and that corresponds to the level of L4, and that's where you will insert your needle. So the needle, as you can see, will pass through between the two vertebrae. It will pierce the dura mater, pierce the arachnoid, and you enter the subarachnoid space. and then you can withdraw fluid, and then if you want, and then study that fluid, and then if you want to inject an anesthetic agent, you still withdraw fluid and then inject your anesthetic agent. So that's where lumbar puncture is done, and usually 5 to 15 ml are withdrawn during a lumbar puncture. Now, if there is a high intracranial pressure, suppose somebody has some problem where the intracranial pressure is very high, then lumbar puncture is contraindicated, because when you withdraw fluid, you kind of create a vacuum and the brain can herniate, especially the cerebellum can herniate or go down the foramen magnum. So you never do a lumbar puncture when there is high intracranial pressure. Now here we are looking at the clinical applications. I've already mentioned this optic nerve and the subarachnoid space. So here you can see the blood vessels as they are passing through, and if there is high intracranial pressure, so suppose the subarachnoid space, the pressure is very high, it can affect these veins or the artery, and usually the veins tend to collapse, which means that venous drainage is impossible. So then these veins inside get dilated, and then in the retina, when you're looking at this region of the retina, you can actually see that. So that's raised intracranial pressure. Before you do anything, a good thing to do is examine the eye and look at the retina. Now let's look at the hemorrhages which are seen with respect to the various spaces. So if somebody sustains a head injury and the skull cracks, what will happen is that the meningeal vessels can be torn, and then you have hemorrhage present between the dura mater and the skull. So this is known as extradural hemorrhage. So an extradural hemorrhage, it could either be arterial or it could be venous in nature. So it could, because the meningeal blood vessels are lying there. Often when such a hemorrhage occurs, what happens is that the person is concussed initially because of the blow to the head. Then if it's a venous hemorrhage, very often the hemorrhage takes a while, the clot takes a while to form. So in such cases, the person initially suffers a loss of consciousness. So they lose consciousness, there's a loss of consciousness, and then they get up after a while, and during that time the clot is being formed. So they have a period of what is known as lucid interval. That means they are absolutely clear and they look normal. So during that lucid interval, this clot is actually taking time to form. And then once the clot forms and it is large enough to cause compression on the brain tissue, as you can see here, again there is a loss of consciousness. So this is very, very typical of extradural or even subdural hemorrhage, where you have an initial phase of loss of consciousness, and then the person gets up, they are fine, so that's the lucid interval, and then suddenly they collapse, so they have loss of consciousness again. And this is often seen in football players and people in contact sports, where they they sustain injury to their head and they lose consciousness for a while, they get up and they are absolutely normal, and you think everything is fine, and then suddenly they collapse again and they end up being paralyzed, or some other neurological deficit is seen. So anything where they have a loss of consciousness and you suspect head injury and they then they become okay, you always have to watch those patients. That's why patients who have head injury are always watched for at least 24 hours. So that's extradural hemorrhage, and it can be arterial or venous in nature. Subdural hemorrhage is always venous in nature, and the reason is that you can see these are the cerebral veins which are present here in the subarachnoid space. They pierce the arachnoid mater, pass through the subdural space, pierce the dura mater to go and open into the venous sinus. So in this subdural space you have only veins, which is why this bleeding is venous in nature. Often this kind of injury occurs, as I mentioned earlier, in shaken baby syndrome, where a baby is sort of held and shook real violently, and then because the brain is moved around in this fashion, these veins are very thin, they tend to tear, and that is seen there. And sometimes often in injuries which are known as contra-coup injuries, that means you have injury on one side and then the brain is pushed to the other side, and so again these veins are moved from their position, they may tear, and again you have subdural hemorrhages. and that's always venous in nature. This also can have that lucid interval because veins tend to bleed very, very slowly, so it takes a while for the clot to form, and then the clot causes pressure on the cerebral hemisphere. So during that time you may have a lucid interval. Subarachnoid hemorrhage can be either venous or arterial in nature because you have arteries and veins in the subarachnoid space, and often when you do a lumbar puncture, the cerebrospinal fluid is normally clear, but when you withdraw the fluid in a subarachnoid hemorrhage, the fluid is blood-stained. Of course, by that you cannot tell whether it is arterial or venous. It could be either. So these are some of the clinical applications of the meninges. Now let's look at cerebrospinal fluid, how it is produced and some of its characteristics. Cerebrospinal fluid is formed by something which is known as choroid plexus. It is formed inside the cavities of the brain, and these cavities are known as ventricles. So inside the cavities of the brain, known as ventricles, you have a tuft of capillaries which is called the choroid plexus, and this choroid plexus is so this capillary plexus with its endothelial lining. So let me just write that down. So you have a capillary plexus with its endothelial lining, then you have pia mater, and then you have the ependymal cells which line the ventricles. So the ependymal cells which line the ventricles here. So these three structures together form the choroid plexus, and this choroid plexus is responsible for forming cerebrospinal fluid. Now the characteristics are the cerebrospinal fluid is always clear, straw-colored, and if ever blood-stained, then you tend to suspect that there is subarachnoid hemorrhage. Usually about 125 to 130 ml is the amount of cerebrospinal fluid that is present within the ventricles and the subarachnoid space. Of this, 25 ml is present in the ventricles and about 100 ml in the subarachnoid space. The pressure is between 60 to 150 millimeters of water. It contains slight amount of proteins, very slight amount of proteins, but contains glucose and a lot of chlorides. Usually you don't see many cells. Up to 3 is considered normal. If you see more than 3 cells inside, then like red blood cells or more lymphocytes or neutrophils, then you know that there is some infection or some problem in the brain. Now let's look at this cerebrospinal fluid and the ventricles. So here we have these ventricles, and these ventricles are cavities which are present within the brain. So you have the lateral ventricle, you have 2 lateral ventricles, one in each cerebral hemisphere, and you can see that these lateral ventricles are C-shaped structures, and this is present in each cerebral hemisphere. Each lateral ventricle communicates with the ventricle which is present in relation to the diencephalon, and that ventricle is known as the third ventricle. The diencephalon is a region of the brain which is made up of the thalamus and the hypothalamus. So you have the thalamus and the hypothalamus in this region, and between the thalami and the hypothalamus is the third ventricle. Now the lateral ventricle communicates with the third ventricle through a little foramen present here, and that foramen is known as the interventricular foramen, or also known as the foramen of Monroe. So each lateral ventricle, you can see, is communicating with the third ventricle through this interventricular foramen. The third ventricle then is continuous with a very narrow channel which is known as the cerebral aqueduct, and the cerebral aqueduct is present in a part of the brain which is known as the midbrain. So the cerebral aqueduct is present in the midbrain. this cerebral aqueduct is a narrow channel, and then it opens into a much wider channel which is called the fourth ventricle, and this fourth ventricle is present between the pons and the medulla. These are present ventrally, these are ventral, and the cerebellum, which lies dorsal or which forms the roof. So the cerebellum lies dorsal or forms the roof of the fourth ventricle. The fourth ventricle is continuous with the central canal of the spinal cord. So you can see that over here. So this is a primitive picture. So this was the initial neural tube, and this is the brain tissue. So you can see how the cavities were so small, the cavities were so large and the nervous tissue was so little. And here we have this large lateral ventricle communicating with the third ventricle, and this is the part which is going to form the interventricular foramen. The third ventricle communicates with the aqueduct with the fourth ventricle with the central canal. Now, as the brain tissue started growing, the cavities got smaller and smaller, and then you ended up with these cavities being just this small. So that's why they're only able to hold 25 ml of cerebrospinal fluid. So again, the lateral ventricles are in relation to the cerebral hemispheres. They communicate with the third ventricle, which is related to the thalamus and the hypothalamus, which form part of the diencephalon, and they communicate with the third ventricle, the lateral ventricles. They communicate with the third through the interventricular foramen. The third ventricle becomes continuous with the cerebral aqueduct, which is related to the midbrain. And then the aqueduct becomes continuous with the fourth ventricle, which is related to the pons and the medulla ventrally and the cerebellum dorsally. So these three are related to the fourth ventricle. The fourth ventricle continues with the spinal cord, with the central canal of the spinal cord. So this is all inside the brain. However, in the fourth ventricle, you have three openings. Two present laterally. So there are two openings present laterally. These two openings present laterally are known as the foramen of Luschka. These are called the foramen of Luschka. And then you have a central aperture, which is called the foramen of Meningeal. Or this is a median aperture, foramen of Meningeal. It should be capitalized, foramen of Meningeal. So let me write that again, just in case you couldn't see. So that was Luschka, and Meningeal. Meningeal is the median aperture, Luschka is the lateral aperture. So you have two lateral and one central aperture. So from these two lateral apertures and from this central aperture, the cerebrospinal fluid, which is produced in these ventricles, passes out and becomes continuous with the subarachnoid space. So here, if I was to draw the subarachnoid space this way, you can see the cerebrospinal fluid will pass out from the ventricles and become continuous with the subarachnoid space. So this choroid plexus is present in all of the ventricles, but mainly in the lateral, the third and the fourth ventricle, the largest part being in the lateral ventricles. So it's produced in these lateral ventricles, passes through into the third ventricle where again a little bit is produced, passes into the aqueduct, into the fourth ventricle, and then into the central canal of the spinal cord. So all of this is within the brain and the spinal cord. But it also passes out through the foramen of Luschka and Meningeal into the subarachnoid space. So that's how you find cerebrospinal fluid in the subarachnoid space. So you can see that CSF surrounds the brain on the outside, and it's also present on the inside of the brain and spinal cord. So it's very, very important because it functions as a shock absorber and protects important structures, is important for waste removal, transports hormones, It helps to nourish the central nervous system and, gives buoyancy to the brain. So let's now look at the circulation and the absorption of the CSF. So we saw that it was produced in the ventricles. So here, if you're looking at a side view, you can see the two lateral ventricles. You can see how they are communicating with the third ventricle through the interventricular foramen. This third ventricle continues into the aqueduct. The aqueduct becomes the fourth ventricle. The fourth ventricle communicates with the central canal of the spinal cord, which is this one. So this is the central canal of the spinal cord. So this is all inside the brain. Now, on the outside of the brain, which is here, you can see that you have the subarachnoid space. So how is this getting CSF? From this fourth ventricle, and it's only the fourth ventricle which communicates with the subarachnoid space, it has these two lateral apertures and it has this central aperture. So through these, the CSF passes out into the subarachnoid space. So you can see how it's passing out into all of the subarachnoid space and hence surrounding the brain on the outside. So that is the circulation of CSF. Now, the CSF is being produced continuously. About 300 ml is produced in 24 hours, and like I said, most of it is produced by the choroid plexus. A little bit is produced by the parenchyma of the brain too. So the parenchyma of the brain also produces the CSF, but most of it is produced by the choroid plexus. Now, as it circulates on the outside, you can't keep on producing CSF without removing it. So it needs to be removed, and that removal or absorption is done in the venous sinuses. And if you remember, I mentioned something known as arachnoid villi. So if you look up here at this image, so this is the subarachnoid space and this is below the arachnoid mater. Now this arachnoid mater sends in little globular structures which are known as arachnoid villi. And these arachnoid villi, as you can see here, pierce the dura mater and open into the venous sinuses. And if you were to actually look at the arachnoid villi, it actually is somewhat like this. It has a little channel in, and let's say this here is the subarachnoid space. Now the pressure in the subarachnoid space is always more than the pressure in the venous sinus. So the cerebrospinal fluid present here will pass out through this channel into the venous sinus. You can see it will pass out through this channel into the venous sinus. Blood does not flow from the venous sinus into the subarachnoid space, because the moment the pressure increases on the outside, it pushes the arachnoid villus and closes this channel. So blood will never pass from the sinus into the subarachnoid space, but CSF will always flow from the subarachnoid space into the venous sinuses. So that was why we have those venous sinuses present in the dura mater, and you can see how these arachnoid villi are piercing the dura to open into the venous sinuses. Now, the importance of knowing all this is that there can always be problems. So let's say that there was a problem up here or even here in the interventricular foramen. So let's say the interventricular foramen was blocked. So what would happen? Fluid would be produced in the lateral ventricle, but it cannot pass out into the third and thereby go out. So the lateral ventricles would keep on increasing in size because whatever CSF is being formed, they can't be passed out. So then this lateral ventricle would increase in size, and it would be at the expense of the brain tissue. And now, since this ventricle is not communicating with the rest of the ventricles, then we call this a non-communicating type of hydrocephalus. So this condition, where there is an increased production of CSF or decreased absorption of CSF, or there is a problem in the CSF, in the circulation of the CSF, we call that condition hydrocephalus. And as you can see in your notes, you saw there was overproduction of CSF, or there was problems in circulation, or problems in absorption. So here you can see there's a problem in circulation. So it keeps on getting formed in the lateral ventricle. All that is formed in the third and the fourth ventricles will circulate normally, but here there's a problem in the circulation. So this CSF keeps collecting in the lateral ventricles, and it is at the expense of the nervous tissue. Now, since this ventricle does not communicate with the others, it's called a non-communicating type of hydrocephalus. Now, the second type where there could be a problem is, the problem could be the aqueduct is blocked, or again either of all of these foramina are blocked. So then again the circulation, this is a problem in circulation. So you can see that if the aqueduct is blocked, then you can see that the lateral and third ventricles will increase in size. If for example these foramina are blocked, then all the ventricles will increase in size, and there'll be hardly any fluid present in the subarachnoid space. Now, the second way there could be a problem is if there's an overproduction of CSF. This is rare, and usually the overproduction is because there is some sort of a tumor of the choroid plexus, and that is known as a papilloma of the choroid plexus, and that's a pretty rare condition. Most often it is because of circulatory problems. The third way is where there is a problem in absorption. So let's say that the arachnoid villi up here, the arachnoid villi are, for some reason, they are damaged, they are atrophied. So they are atrophied. So then what happens is that CSF is being produced normally, it's circulating, it's going into the subarachnoid space, but now it's not able to get into the venous sinuses. And this kind of hydrocephalus is known as a communicating type of hydrocephalus, because the ventricles are all communicating with each other and with the subarachnoid space. Usually this happens if somebody has, it could be congenital, that means these arachnoid villi are atrophied at birth, or the problem can be if somebody suffers from meningitis, or there is some other problem and adhesions form. Adhesions form, and they kind of make these arachnoid villi stick to each other, and they kind of close them off. So then the CSF keeps getting formed, so not only is it at the expense of brain tissue on the inside, the subarachnoid space is also dilated, so it pushes it from the outside, and here then the intracranial pressure will rise. And you will see in the next picture, if you look at this picture, you can see this is showing you hydrocephalus. In this, the child's head is extremely large, and if it's a problem with absorption, this can be helped by putting in a shunt, where you can see one end of the catheter is present inside one of the ventricles, and the other end of the catheter is taken down, and you can push it into the abdomen, into the peritoneal cavity, or sometimes they even take the catheter and push it into one of the jugular veins, so that it helps to drain the CSF. Now the absorption, as I said, is most of the time is into the venous sinuses, but sometimes, some of the absorption, a little bit of the absorption is in lymphatics and in some spinal veins, in some of these spinal veins. Now, since some of the CSF drains into the lymphatics at the base of the brain, these lymphatics in turn drain into the cervical lymph nodes. So we use this knowledge, and how we use it is bimanual downward massage of the sides of the neck is sometimes used to enhance this drainage in patients who are suffering from cerebral edema. So that helps sometimes in cerebral edema. Now there's a condition which is known as Arnold-Chiari malformation. Chiari malformation. This is a congenital condition seen in infancy where the posterior cranial fossa is not developed properly, and because of that the cerebellum tends to get extruded through the foramen magnum, and it kind of blocks the passage there. So here again the fluid is not able to drain properly and the child's head gets very, very large. And that condition is known as Arnold-Chiari malformation. Now let's go on to the next topic, which is blood-brain barrier, which is very, very important. And in order to function optimally, the central nervous system requires a very, very stable environment. And hence it's isolated from the blood by two barriers. One is called the blood-brain barrier, and one is known as the blood-CSF barrier. So the blood-CSF barrier. And this blood-brain barrier and blood-CSF barrier is both a physical barrier and also a system of cellular transport mechanism. Now this blood-brain barrier was actually discovered accidentally when people were doing experiments and a dye was injected into the bloodstream, and they noticed it was a vital dye which stains body tissues, and they noticed that all body tissue was stained except for the brain and spinal cord, and only a very few areas in the brain showed staining. So this led to the hypothesis that probably there was a barrier in the nervous tissue of between the nervous tissue of the central nervous system and the blood, and in those areas where staining was seen, the barrier was absent. And that's how they came up with this blood-brain barrier. Now some important things to remember about the barrier is that the permeability of the barrier is inversely related to the molecular weight. So the larger the molecules are, the less the permeability, which is why big large molecules like proteins are not able to cross the blood-brain barrier. The second thing is that the permeability is directly related to lipid solubility. So substances which are lipid soluble are permeable. Substances which are not permeable. And substances like ethanol and caffeine, which are lipid soluble, pass very easily into the brain, and probably that's the reason why they affect nervous functioning so easily. And large molecules, as I said, like plasma proteins, are not able to cross the barrier effectively, whereas small molecules like glucose and electrolytes pass through slowly, but even smaller molecules like gases and water pass through readily. Now let's look at the blood-brain barrier and what it's formed by. And here we see, and if you look at this picture here, this is the lumen of the capillary and this is the blood inside. So the lumen of the capillary is separated from the brain tissue, which is here. It is separated by the endothelial cells of the capillary, their basement membrane, and the foot processes of these astrocytes. You can see these are the astrocytes. If you remember, those astrocytes had their processes sitting on the capillaries. So if you look at it here in this picture, you can see this is the endothelial cell of the capillary, the basement membrane surrounding it. This is the basement membrane surrounding it, and then these are the foot processes of the astrocytes. Now most endothelial cells everywhere in the body are fenestrated. That means the endothelial cell, this is one endothelial cell, they have small gaps between them, and that's what is meant by fenestrated. So they have little gaps between them. These are called fenestrations. Now in the brain, these capillaries do not have this fenestration. In fact, they are tightly packed together, and those are known as tight junctions. And it is thought it is because of the presence of this tight junction that large substances cannot pass through and go out into the nervous tissue, and that's why this barrier is present. So here we say that the barrier, the blood-brain barrier, is because of the tight junction present between the endothelial cells. And this, the basement membrane and this part over here, this is a lipid layer, so it allows lipid-soluble material to pass through. Now, the hypothalamus is one area. If you remember, I said there are certain areas in the brain where the blood-brain barrier is absent. The hypothalamus and the posterior pituitary are areas where this blood-brain barrier is absent, and here the endothelium has these fenestrations, and this helps because it allows the receptors of the hypothalamus to sample the chemical content in the plasma, and thereby it brings about appropriate modifications which help to protect the nervous tissue. So it's absent in those areas which really need it, but in other areas this barrier is present so that it prevents the nervous tissue, it protects the nervous tissue and prevents harmful substances from coming in contact with the nervous tissue. Let's look at the blood CSF barrier, which you see here. And here this blood CSF barrier allows free passage of water, gases and lipid-soluble material to pass from the blood to the CSF. So it allows this to pass through quite easily. But again, large molecules like proteins and very, very large complex sugars, with the exception of glucose, large protein molecules and large large carbohydrate molecules are not able to cross through. Now the barrier is very similar to the blood-brain barrier, and here the lumen of the capillary is separated from the CSF again by endothelial cells, but these endothelial cells are fenestrated. So you can see these little fenestrations here in the endothelial cells. They have their basement membrane, and then you have the ependymal cells. So this is the ependymal cells with their basement membrane. So these are the ependymal cells, are also known as choroidal epithelial cells. Now these choroidal epithelial cells have tight junctions. So if you look here, you can see these tight junctions present between these choroidal epithelial cells. So while these are fenestrated, substances pass through from here, they can get here, but they can't get into the lumen of the ventricles because of these tight junctions. So here it's the tight junctions between these choroidal epithelial cells, or also called ependymal cells. So these are the ones which pose the barrier and are responsible for the blood CSF barrier. Now what is the significance of these brain barriers? Under normal conditions, these barriers, they are semi-permeable because they allow some substances to go in and they prevent others. So under normal conditions, these barriers are protective, and they allow important nutrients to enter the brain tissue but prevent potentially harmful substances from injuring the nervous tissue. And as I mentioned, nutrients such as glucose and gases, they enter easily, but toxins are prevented from access. But sometimes the barrier is damaged, or it is not formed properly, like in the fetus. And in the fetus, the barrier is not well developed. So what happens is that it allows substances to cross through. So that's why in the fetus we are very, very careful about, when a woman is pregnant, we are very particular about what drugs we give her, because that can cross through the placental barrier, and then in the fetus they can cross the fetal blood-brain barrier. Now because it is not well formed in the fetus, what happens is, especially in RH incompatibility, you have an RH negative mother who has an RH positive fetus. The first pregnancy is fine, but in the second pregnancy, if she has formed antibodies and she has not been treated, these antibodies will pass through the placental membrane and they go into the fetus. Now in the fetus, the blood-brain barrier is not well developed, so the blood cells are hemolyzed, and when hemolysis occurs, a substance known as bilirubin is liberated. This bilirubin is a large molecule, and this now can cross the fetal blood-brain barrier, and it leads to yellowing of the brain, and it goes and deposits in very important areas, and it causes a condition which is known as kernicterus. So that's why RH incompatibility is something you want to avoid when an RH negative mother is carrying an RH positive fetus. So that's one important clinical application. The second is injury and cerebral edema. Now sometimes when there is injury to the brain tissue, either as direct trauma or there is an inflammation due to toxin, then the barrier breaks down, and then when it breaks down, large molecules then diffuse into the nervous tissue, and because probably there's a disruption of the tight junction, so those tight junctions are disrupted. So when these toxins and large molecules diffuse into the nervous tissue, they create an osmotic effect and they pull water into them, and that's why you end up with a cerebral edema. And here you can see a normal picture. You can see this normal CT scan, and you can see the sulci, and you see the brain tissue, you see the ventricles and everything outlined clearly. This is a picture of cerebral edema where everything appears really fuzzy, and that is because, you know, the brain has swollen up, so there's a swelling of the brain. So again, injury can disrupt the barrier. Now in hypertension, hypertensive encephalopathy, what happens is in patients who have hypertension, suppose the blood pressure exceeds a certain level, then the arterioles are not able to exert any control. So there what happens is that the high pressure then opens up the tight junctions in those endothelial cells. So it opens up the tight junctions, and then the plasma exudes outside into the extracellular space, again causes edema, and then you get this hypertensive encephalopathy where the patient may have headache, vomiting, convulsions, and, you know, even lead to coma. So that becomes a problem with when someone's hypertension is uncontrolled. The next is infections and antibiotic administration. Sometimes when there is infections of the brain or meninges, again, as I said earlier, the barrier is broken down, but we can exploit this because now the capillary walls become porous, and all those non-lipid soluble antibiotics which normally did not cross the barrier, now you can make use of them. So now they'll be able to cross the barrier, and you can then treat the condition. And an example, normally when a patient is given penicillin for any condition, only a small amount enters the central nervous system, which is fortunate because penicillin in high concentrations can be toxic to nervous tissue. But in the presence of meningitis, the meninges become permeable locally at the site of inflammation, so they allow adequate antibiotic to reach the site, and you can treat that condition. Now, some drugs which cross the barrier, it's good to know that which drugs cross the barrier. Some examples are chloramphenicol is one drug which crosses the barrier. Tetracyclines are others which cross the barrier. Then you have sulfonamides. They cross the barrier, and so you like to use these drugs. Also certain lipid soluble anesthetic agents like thiopental. This is lipid soluble, so it crosses the barrier, and it rapidly enters the brain after IV administration, and so produces anesthesia quite fast. Whereas non-lipid soluble substances like norepinephrine, they can't cross normally. Also, drugs which bind to plasma proteins, because plasma proteins are so large, they cannot cross the barrier normally. So, if you have to keep that in account. And one good example is in Parkinson's disease, there's a neurotransmitter called dopamine. And this dopamine is deficient, and that is responsible for the various symptoms of Parkinsonism. And neurotransmission doesn't occur normally in people suffering from Parkinson's disease. Now, dopamine can't be given as a method of treatment to treat Parkinsonism since it does not cross the blood-brain barrier. However, L-dopa, which gets converted to dopamine, this is given because this crosses the barrier, then crosses the barrier, gets into the brain, then it's converted to dopamine, and that's how you treat patients with Parkinsonism. So that's the importance of knowing about the barrier and which drugs can cross and which drugs cannot cross the barrier. Now, brain tumors, brain tumors frequently possess blood vessels which have no blood-brain barrier. So usually the blood vessels inside brain tumors, they do not have a blood-brain barrier. And we use this because when we give radioactive tracers, which normally are too large to penetrate healthy capillaries, in brain tumors they can penetrate those capillaries and they can, you can detect these tumors. And this is one such scan which is seen where you can see these tumors present here in this region, and these are those radioactive tracer dyes which are showing up these tumors in the brain. So again, that's important to know. So that concludes this presentation, and for the entire introduction and the meninges and the CSF, it's important for you to listen to it very, very carefully, take notes. Any clinical application is important, and look over this or listen to this more than once. Listening to it the second time, you will sometimes hear things you missed the first time.